Dr. Kenneth Gelman of IVFMD, and we're also going to go live on Instagram as well. So please type your questions in the chat. We're happy to answer them for you. And let me go ahead and go onto our Instagram as well. So bear with me a second. Hi, everybody. We're live tonight, and we're with Dr. Kenneth Gelman. We actually are on YouTube, so I'm going to actually post this in the link for everyone on Instagram to just go on there if you're able to. And let me just post that on our page. Oops, let me see here. Okay, awesome. Okay, so for those of you on Instagram, I just posted the link for our Q&A on YouTube. This is the first time that we've done this. So we're kind of streaming on two things at once. And Dr. Gelman is actually going to be seen on YouTube, but you can listen to him on our Instagram. So welcome, and thank you guys for joining us. If you'd like to ask any particular questions, you can post them on Instagram, and I'll answer them, and Dr. Gelman can answer them too. And also, we're going to be answering them on YouTube. So thanks, guys. And Dr. Gelman, if you could just tell us a little bit about yourself, that would be great.
Well, I'm Dr. Kenneth Gelman. I've been with IVFMD for 6 years now. I was formerly on my own, in my own practice in reproductive medicine. I've been doing this for quite a while. It's a pleasure to be here tonight and to answer your questions and, talk generally about things too. And, I'm just so happy not to be talking to people without a mask on.
Yeah,
this is like, oh my gosh. And I'm sure that a lot of you feel the same way once you get home, what a relief it is.
Yeah, definitely.
We obviously in Florida down here, we have to be very careful because the numbers seem to be going up. But we're still, working, and we're still there, doing what we need to do, helping people. Our cycles are still going. Nothing's changing. We're just, taking all the necessary CDC precautions. So all of you that are, thinking about coming in or you're currently going through, don't worry, you're safe. We're using all the current precautions that we're supposed to use. And so I hope you all feel comfortable. Mm-hmm. So if any of you have any specific questions that we could go over for you tonight, we'd be happy to answer those. Anything at all coming up? I know there was one question about frozen embryo transfers.
Yes. Let's start with that. So you can expound on that a little bit about the frozen embryo transfer question we had.
Well, I think the most places around the country pretty much are almost, I would not say exclusively, but pretty much are all going to the use of frozen embryo transfers, which means the IVF, fewer places are doing fresh transfers exclusively, but there's situations when those are still being done. But it seems like the data for frozen embryo transfers is as good or better in terms of success rates. Mm-hmm. So our practice almost exclusively does that now. So your IVF essentially is done in two parts. The first part really is just creating embryos, retrieving the eggs, fertilizing the eggs, and creating embryos, and then freezing the embryos. Or a lot of people are also doing PGT, or they're biopsying their embryos for genetic studies, which would require them to be frozen anyway. And then the second phase of the IVF is then transferring those embryos that we have frozen, and everybody pretty much selectively is doing single embryo transfers now, with, again, rare exception in certain circumstances, but single embryo transfer sort of is the rule. So the nice thing about frozen embryo transfer, and this is an answer to the question that was asked, is how do you control things or how do you improve things? And actually, that's one of the reasons why frozen transfers, I think, are better, because you can control things. And now we have the ability, to do several things. I mean, one of the things we typically do is we always will look for any kind of immunologic reasons potentially to have either implantation failure where the embryo doesn't implant, Or if you've had recurrent failures, for example, recurrent miscarriages, a frozen embryo transfer would give you the ability to not only have that embryo tested genetically to ensure with at least a 95%, 98% chance that that's a normal embryo conclusively, so it's not 100%. But also you have the ability to check the immune system and to use something like intralipid or Lovenox or sometimes IVIG, but also control the day of the transfer. Some people we now think require maybe a different day of the transfer versus a generic frozen transfer protocol, which means normally people are transferred on the 6th day of progesterone administration. So there's now tests called, the ERA test, for example, is one, endometrium receptivity assay, that can actually detect what your personalized window of implantation might be. And we think that that test is useful. And it seems to increase, implantation rates at least 25%. Some studies say 15%, but I found that it's actually useful, particularly in people who have had losses before. And we think it's related maybe to progesterone administration, or they didn't implant the embryo and it was genetically normal. That might be a good test to do. So, the frozen embryo transfer, you have a lot more control over. Additionally, the other thing that's very important, I think, is that in women, particularly under maybe 35, who have frozen embryos, a lot of them, and it's actually being shown that maybe a natural cycle frozen embryo transfer without any meds, just letting the women ovulate, maybe giving her some progesterone, might be a really good thing to do, because the pregnancy rates seem to be quite high doing that. And that allows you to obviously use a lot less medications. It's cheaper, and you're sort of letting your own body do the work and not giving, not artificial, but you're not giving all these extra medications, which some people, don't really particularly like, or they may have side effects from, and again, the expense. So the natural cycle transfer is a pretty cool thing. And that's being done. We've done, many of those, and it's worked well. Sometimes we even give them a little femara to make them ovulate, to ensure ovulation. So, that's something that you can consider in those frozen transfers. So I think the frozen transfer in general really is a great thing. It's a great tool. And I think, all these things that I've mentioned, are proving it to be that way. And, as more and more research comes out, I think we'll probably see that that's the way to go. So I hope that answers that question.
Very cool. What would you recommend for somebody who is just trying to start treatment and kind of not sure where to start? Like, where would you say to start first? If they're struggling with fertility issues and maybe they've been seeing their gynecologist and they're not really sure which way to go.
Right. Well, it depends on the patient. I mean, it depends on the age. Depends how long they've been trying. We see a lot of referrals or patients coming from gynecologists. And, typically, gynecologists who are very busy people, don't spend a lot of time necessarily discussing a lot of the fertility aspects that, go on with a particular patient. They may just say, listen, if you're not getting pregnant after X number of months, sometimes just keep trying, again, depending on the age, or they may, automatically give you 3 cycles of clomiphene or 4 cycles, and, they'll probably do an HSG to make sure the tubes are clear, maybe a semen analysis, and then give you, 3 or 4 cycles of clomiphene. And then when those people fail, they end up, coming to us. So at that point, they've already sort of tried ovulation induction in one sense or another. And, assuming that these women have ovulated or responded and their tubes are normal and the sperm's normal, they usually are more motivated to step things up at that time. And again, depending on the age, they may go right to IVF at that point, because of the success rates and the advantages IVF has over everything else. Or, some people might try adding artificial insemination or things like that, which, that may have a modest effect in their particular situation, but, quickly work.
Mhm.
And again, depending if they have endometriosis or not, which will obviously impact their success rates, and certainly will take them longer to get pregnant. That has to be determined, or whether that's playing a role here, and whether other therapies such as IVF might be much more effective from the start, instead of wasting month after month after month where things aren't working, and it's getting very emotional and tiresome, and people get really tired of this, and it's very understandable. It causes a lot of stress and a lot of anxiety, and that's why fertility therapies, effective ones, are really very, very good, and help a lot of people.
I think it'd be great. I'm trying to actually ask on YouTube for everyone to type their questions in, and also on Instagram. So you guys give a little shout out and say hello, and type in some questions. If anything that's been on your mind that you'd like to ask, that would be great. And then also we're wanting to hear about any concerns that you might have if you are starting treatment, or you're thinking about, or you've been struggling with endometriosis, PCOS, secondary infertility. And we do see quite a bit of that, where a patient will come in and say, okay, I've gotten pregnant easily. I conceived naturally my first time, but now I'm having a problem. So, that's one of those issues that we see quite a bit, and it's a shock, because nobody ever expects to have an issue like secondary infertility crop up after you've had healthy children and been pregnant naturally. So are you seeing that also in your practice, where,
Oh yeah, I mean, we see that's very common. Again, as you mentioned, I mean, a lot of times that may be due to the age of the patient that comes in. I mean, they might have had their first child, when they're 28, and they come in and now they're 36, 37, or whatever it is, a second marriage. And, it could be related to, a decreased ovarian reserve. I mean, there's possibilities such as that. I mean, we see women, sometimes in their early 30s or younger, with really decreased ovarian reserves. And we always try to figure out what that's from. Is it genetic? Is it some kind of occupational exposure? Is it something that they're doing that's doing this? I mean, we never really find an answer on that a lot of times. But or advanced age, particularly, and egg quality. So those things really make a difference, and that's why we always try to tell women, try to have your kids early if possible. If not, consider freezing your eggs, because it's a very potent advantage you will have. Should things change in your life. Nobody can really predict the future. Nobody could have predicted this COVID thing. And God knows what's going to happen next year. If they don't have a vaccine by then, or if it's not effective, or it has bad side effects, or God knows. I mean, these are the things maybe you want to think about, is freezing your eggs and protecting yourself, because it's the only thing you can really cryopreserve in this life. What else can you cryopreserve? Nothing. So, you may want to think about something like that to avoid even secondary infertility. I mean, I've had people come in and they're doing it really because they want to preserve the ability to have their second and third child.
Mhm.
Not because they're even trying to get pregnant. They just want to preserve the ability to have their second and third child.
And
So they come in and they freeze their eggs. And that's really thinking ahead.
yes.
That's really smart thinking.
Are you
Because
doing a lot of cycles with the frozen eggs now, or are you, since it's been around for a few years now, where the technology?
Well, we do. I mean, we're really starting to do that now. I just discharged a patient today who did extremely well. She at 38, and her story was basically, she got scared because her brother's friend, or brother's one of his friends, I guess it was a woman, was 41 or 42, I guess, was in a marriage there, and tried IVF 6 or 7 times at 41, and had no eggs, basically, had very poor egg quality, and had to quit. And they couldn't even adopt, they couldn't do anything. So, and their excuses, they're very happy, having the cousins and and the nieces and nephews. But, I got to imagine that's got to be very, very difficult emotionally. So this woman, very smartly froze her eggs. I mean, she did 2 cycles. She had amazing fertility. She was one of the lucky ones, and has many embryos now frozen. And she and she had a transfer, several weeks ago, and I just discharged her to the OB/GYN successfully.
Oh, good.
So, it was a very good story. And, we've had several of those over the last, months. But I think that's one of the smart things to do to avoid this secondary infertility problem, because, you never know. I mean, your new husband maybe has a male factor problem. Who knows? We don't know unless you get tested. So the other thing is, if you're remarried or in a new relationship and, you're thinking about fertility in any way, and you're 36, 37, 38, come in, call us up, come in and get a fertility assessment. Now, what is the fertility assessment? It's simple. You come in, you obviously have a consultation. We go over your history. We see what kind of potential issues are there. Do you have endometriosis? Do you not have endometriosis? Did you have a complicated pregnancy? Do you have thyroid disease? Are you diabetic? Things like that. Are you overweight? So, that may be something that we're going to want to obviously try to improve before you get pregnant. But as far as fertility assessment, you'll do day 3 labs. We'll do on the 3rd day of your cycle, we'll do an ultrasound. We'll look at your ovaries, and we'll count your what's called your antral follicles, which are your little eggs that come up to the surface of the ovary, and they look like little chocolate chips, like a Chips Ahoy cookie. So if you have a Chips Ahoy cookie and you take it and you look at it and you hold it in front of you, and if your ovary looks like that, you're in really good shape. So if your ovaries look like Chips Ahoy cookies, you can quote me on the internet. You're in really good shape. So that's kind of what you'll see on ultrasound, and then the lab work will verify that. What's called an FSH test. That's usually on the normal range up to about 10, or no higher than that. 10's a little high actually. And an AMH. AMH is an anti-Müllerian hormone, and that test gives us a level or a number of how many little eggs you have in your egg pool. Pretty cool test. So, and you have to make sure it's an accurate one. It goes to an accurate lab. And we use a very accurate lab, an endocrine lab that has it all standardized, has a very standard value and a very, with a very narrow range of controls. Because if you send it to some of these big labs, they have a very wide range of controls there. You don't know what normal really is for that age group. So you have a very standard, narrow set of controls where you really know what your ovarian pool is. So obviously, if you're falling in the range, and we have a graph to show you exactly where you are, you'll know that, hey, your fertility is really good. And maybe I can wait a few months, or maybe it's a good time to freeze my eggs because I have a really good ovarian reserve. That's a great idea. Freeze your eggs. Or converse, I have a very low ovarian reserve. You're going to have potentially trouble in 6 months if you're not pregnant. So that may mean, hey, maybe you should get into treatment right away, or do something sooner. So it's important that women who are in their mid-30s, certainly, and younger, even, or higher, 38, 39, they get assessed for their fertility potential, especially if you're, if you've had kids before and you're in a new relationship, or you haven't had kids before. Obviously, it's just a simple thing to do, and it will give you, peace of mind, hopefully.
Very cool. Yeah, we just had a patient do really well. She's 38, and she had a ton of follicles, or almost 39, I think. And, just doing the egg freezing because situation wasn't right. Sometimes, maybe the boyfriend is in another country even, or he's not ready yet to have a family, but want to in the future, perhaps. But now she's got, a ton of eggs. They're like really healthy, that are frozen, and she can take, kind of like take a little moment and pause and figure out what to do.
Because if you freeze
right away, it's like it's
if you freeze your eggs are there. You could use them well into your 40s. You don't have to get pregnant in 2 months later necessarily. This could be a year, 5 years, even 10 years later, you could use those eggs. So if you came back when you were 45 or 46, your eggs would be, 25 if you froze them then, or 30, whatever it may be. It's not going to be an issue. And the uterus is not a problem. It's usually not a uterine problem, unless, of course, there's some kind of uterine problem, like big fibroids or adenomyosis or something there that's causing other issues. But
Well,
if everything's healthy there, you can get pregnant in your
Dr.
40s.
Gelman, we are taking some questions. We actually have our first person on YouTube that's commenting that she's about to start her first cycle. So awesome. We're rooting for you, Marcella. And please, if this is your first cycle, it is hopefully your last cycle. But
Yeah.
ask us questions, because we've been doing this for a long time. Probably both of us combined have like 40 years of experience.
Oh my gosh.
Think about it. Yes, we've been working on fertility for a long, long time now.
A long time.
So we are like, we just want you to pick our brains. So she basically says, and we also have a question on Instagram. So we'll get to our YouTube question. And she's 38. How many cycles do you suggest to do the first time? Oh, sorry. Let me make sure I'm reading this correctly here. Okay. How many cycles do you suggest to do the first time? I'm afraid one implantation won't be enough. Thank you. So she's 38 doing her first cycle.
IVF cycle?
Yes. Mm-hmm.
Yeah, I mean, again, it depends, again, a lot of on the history and things like that. But I always tell people, 38, 37, even 25, I've told people that there is a chance. The older you get, the higher the chances. And usually we show you statistics, on how many or what percentage, statistically from IVF studies, what percentage of your embryos would likely be normal chromosomally. So there's a graph we usually show you that, and that tells you, let's say at 38, maybe 60. I can't remember the exact number without looking at the graph, but maybe 60% of the eggs somewhere around then may not be chromosomally normal statistically. But that's over, really, thousands and thousands of patients. I mean, your particular one cycle, you may get 3 normal embryos chromosomally. And that's a great cycle, so likely you obviously have 1 for a transfer and then 2 frozen. But there's also a chance you may have none. So, and then you do that again, and there's your 3 normal. So on the second time, it may happen. And you look at sometimes IVF statistics, they get better and better up to 3 and 4 cycles. It starts to narrow off maybe at 5 or 6. Mm-hmm. But typically, I tell people that you should anticipate 2 cycles, maybe 3 max. Typically, obviously, financially, it's very expensive too. Mm-hmm. But again, you have to look at the whole story here. What your ovarian reserve is, how many eggs we think we're going to get, and your age, and look at the percentage of what we think will get normal chromosome.
Acupuncture. I hope she's doing acupuncture to prepare. That would be great. Those things that will help those success rates actually get higher. And I know that you have a great success rate. So it really, you can look and start.org as well.
Acupuncture would be a great idea. In addition, if you have a low AMH, you may want to do a couple of months of diminished ovarian reserve vitamins like DAGA and, high enzyme, coenzyme Q10, high doses, and L-arginine and things like that. Make sure your diet is really, really healthy, a Mediterranean type diet. Farrar discusses diets all the time. Your BMI, what's your BMI? So all these things have to be looked at in order to give that, a prognostication, how you're going to do.
And Marcella was saying that she will try to freeze 2 good embryos in case one fails to implant. That's good. Yeah, that's a good goal. I mean, hopefully you get more than that. You never know. But that's a good goal to have, and because you don't want to do more than 1 embryo usually, as far as implantation.
Right. Yeah, you'd like to have frozen embryos. A good cycle would be to end up having one transfer and having at least 1 or 2 frozen. That would be a good cycle. So you did well. So, but you always have to anticipate. You have to be cautiously optimistic with this thing, because again, I've seen it too many times when good prognosis patients unfortunately did not get the result that we expected.
Yeah. Thank you for your question, Marcella. We wish you the best of luck. We really do. And we have a question on Instagram. How long do you prepare for FET? This might be, I mean, what we recommend is usually at least 6 weeks of treatment with us. We try to do acupuncture to help with blood flow, to help with getting, the stress level down, getting the cortisol levels good. Even though you're not working with, the number of follicles and not stimulating and all of that, you are taking, sometimes estrogen and Lupron and all those things. And also, it can be that, the lining is not adequate sometimes. So we try to work with our patients at least 6 weeks prior to the actual transfer date. And then we try to appear there during the transfer, if possible, to do acupuncture. And then if we are able to do that, we like to see our patients after the transfer as well, at least till the twice a week until the ultrasound shows a heartbeat. And then once a week during the first trimester, where we concentrate on nausea, vomiting prevention, stress relief, circulation, because it's just as important. That's such a delicate time frame. And there's very little that you can actually do if you have pain as well. Like if you have migraines, you're having shoulder pain, back pain, you don't really want to take Tylenol and that sort of thing if you could avoid it. So acupuncture is very safe to do during pregnancy as well. So what would you recommend for your patients who are, trying to prepare for an FET?
Well, same thing. I mean, exactly that. Healthy diet. Obviously stress levels, and the prep is obviously a little bit easier. It's a little longer. I mean, it takes several weeks, up to 6 weeks, to actually prepare your uterus for a transfer.
Mm-hmm.
So, during that period of time, it's a good time to obviously stay as healthy as you can be, like do your acupuncture, make sure you're having, healthy diet, things like that, and keeping your stress down. But in terms of, prepping for it, it's pretty standard. I mean, in terms of the medications you use, there's obviously special issues sometimes with certain patients, like a thin endometrium you're mentioning.
Mm-hmm.
Some people don't develop a very thick endometrium, and that's always a very difficult problem to deal with on occasion. We try higher doses of estrogen patches. We've tried Viagra suppositories, and those people really doesn't work too well. Neupogen infusions I have experience with several times. Actually, it has worked. To help thicken up the lining and help improve the implantation materials that are needed inside the uterine lining to help implant an embryo.
And what are you looking for in the lining? Is it like a trilaminar, or like what are you looking for?
Yeah, but usually it's very thin. We like to see it over 7. Everybody has this number.
Mm-hmm.
But in talking to several experts around the country, a thin endometrium, according to certain experts, which I'm not sure I believe, is 5 or less. So, and I've had a couple of patients. Actually, I had one where persistently had a very thin endometrial lining. Every time we prepped, we've canceled a couple of preps because she wasn't developing. Started over with higher doses of estrogen, added Viagra, added this and that. We really couldn't thicken the lining above 6. So on one particular cycle, we did this ERA test, this endometrium receptivity assay, where we did a biopsy on the day that we were supposed to do an embryo transfer. So instead of doing the embryo transfer during this person's prep, we did a biopsy. That's called the ERA test. We send it to these genetics people,
Mm-hmm.
and they give you a report on whether all the implantation proteins, under the influence of all the hormones you've given this patient, particularly progesterone, are present. And it turns out she really was receptive on the day that we did the biopsy. So even though the endometrium was thin, her lining was receptive. So we prepped her again. We took a chance, and she had the same exact thing go on. We followed exactly what we did for the ERA test, transfer her, and she's pregnant. So this was a couple of years ago. So it's not always the thickness; it's what's going on inside there. And that's why one of these things, somebody was asking about the frozen embryo transfer things.
Mm-hmm.
You have a better idea of what's going on in the lining. You can actually predict maybe a little bit better those things versus a fresh transfer, for example.
And is the progesterone level that important as well? Like when you're checking the progesterone?
Well, it seems to be, I mean, there's certain studies again that show progesterone levels on the day of a transfer have to be, 20 or so. And some studies show a higher level of progesterone may be indicative of, a pregnancy loss later on. Maybe the endometrium's too advanced. It's yet to be figured out for sure. But certainly a level of 20, 25 is probably adequate, for a transfer at that time. Now, again, some of those people with the thin transfers, maybe it's the Lupron. Sometimes when we give people Lupron and we're prepping these people, it really decreases the blood flow to the uterine lining a lot. That's what Lupron does. So it works against us in some senses, in some patients. So, we sometimes eliminate the Lupron, or we do a natural cycle transfer without any meds and any Lupron. That might give us a much better lining. So, there's a lot of ways to prep, so to speak, for that particular patient and that question that you're answering.
Very neat. Yeah. And I mean, definitely some people get very nervous when they hear their numbers or they look at how many follicles they have or with their old, estrogenism. There's a lot of stress that goes into that. So it's good to know it's not always about the numbers sometimes. I mean, you can have outcomes that are not,
No, particularly when it's stimulating, we get a lot of people with diminished ovarian reserve who are going through, don't develop more than 2 follicles, and we know they're not going to get more than that, but we're just hoping for quality. So it's all about egg quality. You get the right quality egg that fertilizes and develops into a good quality blastocyst, you got a real good shot of, obviously staying pregnant. So that's what it's about sometimes. And sometimes we push people through even with a low amount of follicles. So
yeah, in the past it would usually be like converted to an IUI or something like that. That's really
we could still do that, but I mean, in certain individuals, we know they're not going to do better than that, and it maybe they take a chance on getting a retrieval, and we do, and on occasion we're obviously very, very lucky with that.
Awesome. Well, I think that anyone who's preparing for a cycle, it's good to know that it's not always hinging on the numbers all the time, and things can change. Like sometimes people start out with just a few follicles, and they get actually better responses as they go along. So
yeah.
But definitely, there's more. There's always an option. Like there's different natural treatment, IUI, IVF, frozen embryos. So now, like the technology, there's just so many things, so many options out there, and even for same-sex couples as well. We've had patients.
Well, I was going to say a word about that. That there's something out there that seems to be attracting some attention is the InvoCell, which is a sort of a newish technique for it's sort of a in between IVF and IUI. It's called InvoCell. And really it's sort of a hybrid IUI IVF process. It's kind of cool and it's cheaper than standard IVF. But I think particularly same-sex couples seem to like this a lot because both of them can contribute to the whole process. I mean they do reciprocal IVF a lot, but there's also another way with InvoCell. It's where actually the eggs are removed from one partner and put in this device called this InvoCell device after they stimulate with a sort of a basic fertility stimulation protocol. The eggs are removed just like it would be in regular IVF. They're put into this device. This little small device looks like almost like a salt shaker, and obviously a donor sperm is added. And then that device is put back in maybe to the other partner's, vaginal vault, and that person would incubate that device for 5 days, which is mimicking what happens in the embryology lab or in the tube, where fertilization would occur, and it would take 5 days for the embryo to swim down the tube to implant in the uterus. So we have this device inside the vaginal vault, and hopefully fertilization takes place. So you have to be a good candidate for that part of it, and that that requires an investigation on the partner and the sperm, obviously. But assuming you get fertilization in the device is then taken out and given to the embryologist. They see how many fertilize, and from there, maybe one embryo is taken out and transferred back into the original partner who provided the eggs, who will then carry the pregnancy. So that way, both partners can get involved in this sort of like a hybrid IVF IUI process. The nice thing potentially about it is, there's natural fertilization involved there, and the body is the incubator here. There's always a saying in reproductive medicine: the best incubator in the world is mommy's body.
Yeah.
So it may show a lot of promise. It's been it's just coming out basically, and some places are really having a lot of success with it, and it seems to be attracting a lot of interest.
Yeah.
In couples, who might benefit from it.
That's pretty fascinating, awesome. And
Yeah,
I'm just so happy there's options out there. Really, I mean, if
yeah.
the will is there, there's a way. So, and as far as with the COVID and all that, are you basically still doing the virtual visits, or are you guys?
Well, we're doing both. But we are seeing patients in the office. We're encouraging to come in, and obviously wearing a mask, and we're social distancing, et cetera, et cetera. Everybody's temperature is getting taken, and obviously, the husbands are, coming in. If they're coming in too, they're getting screened also. So, I think there's nothing like an in-person visit. I mean, it's so much more effective. But on the other hand, the doxy or the computer visits are not a terrible second. I mean, they're pretty good for the most part. The only thing is, in an initial consultation, you really can't, check the patient. You can't do an ultrasound that day, and there's things sometimes we do find on an initial ultrasound that the patient may not really appreciate or know that they've had.
Mm-hmm.
Like we find endometriosis in the ovaries, or, big cysts, or, something like that we can't really appreciate on the computer. We're not doing an ultrasound. So it's always good to try to come in person, and hopefully, things stay status quo and don't get any worse, and nobody gets shut down, and none of this stuff, happens, and everything, progresses, and we go through, and we live our lives healthy.
Yes.
And we can still do what we do, but, and that's what we're praying for here.
Yeah.
So, I urge all of you out there, don't be cavalier. Don't walk around without a mask, and still social distance, and, avoid big crowds, and, do your thing, but be very, very careful, because, the numbers in Florida seems to be increasing.
Right.
But you certainly won't have any symptoms maybe for days and days and days, and it's not something to laugh at.
Yeah.
And we want to keep you all healthy out there, and help you get pregnant.
And for sure, if you've had a diagnosis of COVID-19, how long do you wait? How long do you recommend the person wait before they start to try again? I mean, even if they're asymptomatic with that diagnosis.
Well, they gotta be cleared by their internist, and make sure their antibody test. The whole thing with the antibody test is how accurate is everything.
Yeah.
How long are they still disseminating virus, despite the fact that they've got antibodies, and I don't know the definitive answer yet. I don't know if anybody has the answer yet.
Mm-hmm.
But I'd probably give it at least 2 or 3 months.
Yes. Mm-hmm.
After IgGs are detected, and, at least.
Yeah, definitely. I mean, I know it's hard because, people do want to try and that sort of thing, and they feel good. They don't have symptoms, but
Yeah.
That's still important to wait, because we don't know really the effects really on this. We don't think there's a negative effect, but this is a new virus, so
Yeah.
wait a few months until your body can heal and clear. We do have a question on Instagram: is PGS testing available with InfoCell, or no testing can be done?
No PGS testing with InfoCell. It's a no frills IVF. That's why it's cheaper. And I mean, that's not to say if you end up with frozen embryos, you do really well with it. And at some point in the future, you decide you want to have the embryos thawed and frozen, thawed out and tested. We could probably arrange that, I would imagine, although nobody's done that yet. But the actual procedure itself, once you go through with it, is not involving any PGT. So, it's that's what I was trying to say. It's a hybrid kind of IVF IUI process. So it's in between what we can really do with IVF and more so than what we do with IUI.
And the cost is about in between, or is there like?
Cost is in between. I don't know the exact cost.
Yeah.
It's definitely cheaper than, several grand cheaper than regular IVF. So for people, who are good candidates for it, it might be a good option to try. And
on YouTube, we have a question from Marcella. She's saying, can you explain how stress can affect this process? A family member died, and I'm a bit nervous, not sure if my emotions of grief may affect the process. And I'm very sorry to hear that, Marcella, about your family member, and our condolences. And I will just answer this question because we talk about stress a lot in our practice, about cortisol levels. It can affect people differently. So if the cortisol is high, sometimes it's a little difficult. It's almost like your body is in fight or flight mode if you've been under a chronic amount of stress. And acute stress is different than chronic stress. We can have acute stress and be okay and fine. It's just that prolonged stress that tends to be the worst. And that's not good for your health or any of that. But this sounds like a recent event. So definitely check in with yourself and say, is this the right time? And if your mind and your body are, willing to go through this, I would definitely get support, and maybe talk to do some counseling, acupuncture, things to help with your stress management. Yoga is excellent. I wish I could just park a yoga studio next to my office and just have patients do yoga, like everybody together, please. Not everybody likes yoga, but I'll tell you, it is.
Let me tell you,
good for the sympathetic nervous system. And I know you're a yoga component too.
Oh my gosh, yes. There's very good online yoga programs. I mean, I'm huge in yoga. I never thought so. My wife was telling me 20 years ago that yoga was the greatest thing. And I never believed her, was trying to do P90X and do all this stuff. But and as you get older, you find that, not only your stress levels, but, you get stiffer, you get, you just, things change.
Yeah.
And yoga is the antithesis of aging. It really is.
Yeah.
And there's definitely a lot of types of yoga. There's restorative yoga. There's, hot yoga. There's power yoga. I mean, there's different types for different, people. But the hallmark of it is, you'll get tremendous reduction in stress. Tremendous.
It's so good. Yeah. And it's good for cooking. I mean, I'll have to say you're getting a comment on YouTube. What's Dr. G's favorite yoga position? What's yours?
That must have been one of my patients as well. But I'm just saying, you get a tremendous reduction in stress. You get strength. You get stamina, unbelievable. It's really an amazing science. I mean, it's been around for 5,000 years. People are doing this for 5,000 years. They got to know what they're doing over there in Italy, in India.
I mean, it's and I'd say that Ayurveda is probably older than Chinese medicine, and it's a lot of stems from that. But I'll tell you, with grief, I think grief is something that it's unusual. Sometimes it happens in different times, and you might just be in your car, or you might be doing yoga, and when it kind of like hits you. And I remember with my grandmother passing, I was in yoga class in Shavasana, and I was like, wow, and all of a sudden the tears just come out. So it actually, I think it has a great effect in helping us process our stress. We don't realize what we're under until it happens to us. And these sort of things, actually, these mind-body approaches like, acupuncture, yoga, meditation, it connects your brain with your body. And I believe that fertility treatment also uses your brain to connect to your ovaries. So it's really important to incorporate some form of release, I think. So, so I hope that helps. And we are getting a couple questions. Okay, one on.
Let me just add one other thing to that.
Mhm.
It's just that, even if you're going through any IVF treatment or whatever, just the fact that you're, and particularly, a lot of women are professionals. They're coming in really early in the morning, 2-3 times a week. Just the mere ability to do that is adding so much more stress to your life.
It's a second job, yeah.
And believe me, let me say one thing. If men were primarily the problem with infertility and how to carry babies, there'd be about 3 children in this world. I'm telling you. So women are remarkable in their ability to do this and to persevere in this. So, just that ability though to do it though and make the extra time adds so much more stress. So I think, your point is well taken, that you should have some form of meditation, some form of relaxation that you like to do. Just even if you commute, if you're driving to Miami every day, can you imagine that headache?
Oh yeah.
So when you're coming home, you're exhausted. You can go out and take a walk.
Yeah.
Even if you go out and you take a nice walk, or if you have a pool, go in the pool and swim some laps.
Yes.
It's fabulous.
Yes.
Fabulous.
Even at first you don't feel like doing it. It's like once you
once you get in, once you do it, you do it.
Yeah.
You feel so much better.
Yes.
And you sleep better.
Yay. Awesome. Okay, so do you recommend to do a detox before starting in vitro procedure? The detox, I mean, usually with detox, we think, is there been any heavy metals or anything like that? If somebody's coming off a ton of hormones too, like let's say they're stimulating, they hyperstimulate, their estrogen's way through the roof, then you wait a little bit, like a month or 2, right, before doing the frozen transfer to get their hormone levels kind of more even keel, right? So, I mean, I like to do the greens first drinks with our patients, do a lot of fruits and veggies and that sort of thing, just kind of blast with antioxidants to help get those estrogen levels back down, because you can't start a cycle if they're too high also, right? So.
Yeah, not only that, but just in general, even if you're just starting in general, just like you said, the nutrition part of this really has to be stressed. I mean, I think the antioxidants and the healthy eating and all that really has to get stressed, because a lot of people just don't follow it. Like I saw a couple yesterday. I was so impressed. They are completely plant-based diets, completely plant-based, and they were telling me what they're eating every day. And I told them actually to get the Whole Foods Diet book, because the Whole Foods Diet book, the fellow who started Whole Foods wrote a book, and it's a phenomenal book. I don't know if you've seen it either.
I've seen that.
But it's worth looking at it, and he's got a whole bunch of recipes in there, and but it's really a lot of interesting anecdotal stories there. But this couple was so healthy, and what they're eating every day, and they're so calm, and they've all they lost weight, they're healthy as heck. It was very impressive.
That's awesome. Yay. Yeah, there's a great Netflix documentary called Game Changers too, about the plant-based diet. It's awesome if you want to check that out. So we are having some questions on Instagram also. Wait, I hope I answered that question. Yes, the detox. Okay. Instagram is, can AMH change month to month?
Now, AMH is not going to change month to month. Now, unless you're going from one lab to another, and this happens frequently. Some people come in with an AMH, like I had this, I think 2 weeks ago, an AMH of 0.3, very low value. And was told by a gynecologist, you better go get, seen by somebody, because this is not a good sign. So we did an antral follicle count on this person, and she had Chips Ahoy cookies. Just like I said before, Chips Ahoy cookies, I said, this can't be right. So we ran the AMH, and it was, 6. So, be wary of where your AMH gets sent, first of all, and insist on an ultrasound, so that the doctor who, was ordering the AMH can give you a better idea. Is that AMH really correlating with what's going on in your ovaries, or is it just a very spurious value from a lab that really shouldn't be doing an AMH in the first place?
Oh, that's a good
and making people crazy
But
for
yeah,
no good reason.
these home tests now too.
So
Yeah.
yeah, now particularly in young women, the AMH may not be that accurate. In younger women, the AMH may not be that accurate. So it's always important to get an assessment with ultrasound and to see if you have Chips Ahoy or not. Because if you do, and you have really active ovaries, and your doctor can tell, an experienced doctor will be able to tell, you're good. You're good. And again, that's the kind of thing. So, but your AMH in a very good lab is not going to change month to month. It may change in 6 months or 9 months, but generally not, in month to month. So, but things that could change it are, God forbid, if you needed chemotherapy for any reason, or something that was going to affect your ovaries, or something that damaged your ovaries, or major surgery where scar tissue is created and the ovarian blood flow got severely affected. These things could change the AMH over a period of time.
And
but generally, it's not going to change.
They're asking on YouTube, what's the test you just said? It's called the AMH. I'll type it in the chat.
AMH. AMH.
Yeah, and that one is usually, it's a simple blood test that can be done.
The blood test that's done, again, it's got to be done at labs that have a good standardized value, as I said before. Make sure that you have to make sure that the standard value for your age is at a very narrow margin, not a wide margin, because a wide margin tells you nothing about what your AMH really should be for your age. So a place like, we use a lab called Unilab in Davie, which has a very, very good standard AMH, because they've been looking at this value for 15 or 20 years, and they've made their own standards that we use exclusively, really.
Okay, that's awesome. So make sure you go and get the test done at the same lab too, right?
And make sure it's an accurate lab, and make sure everything is correlated with what they're seeing on ultrasound. That's the best way.
Okay, ultrasound too, yes. So so as far as another question is how to improve AMH. Equality, I guess you could correlate, and we do work with that a lot with our, as far as antioxidant support, diet is super important, acupuncture, herbs, omega-3, and sperm health as well. We try to focus on both. There are many ways, and there's a lot of research out there about certain antioxidants too, like ubiquinol and its effects as well. So do you have any other things to add to that?
So the question was egg quality?
Well, how to improve AMH?
Well, AMH may improve slightly. I mean, the other thing I neglected to mention is that AMH may get affected, may be lowered by, let's say you're on birth control pills for month on month. We never thought it did matter, but apparently it does lower it slightly. So if you're on birth control pills, you got to come off birth control pills and probably remeasure it.
And how long do you wait till you remeasure?
I would say 2-3 months.
Okay, all right, that's
to be sure. Now, things that'll improve it. Good health, maybe it'll slightly improve a little bit, but you're not gonna, if your ovarian pool is really diminished, you're not gonna all of a sudden manufacture new eggs. You're gonna help maybe bring eggs up to the surface that you have left, but you're not going to improve, all of a sudden manufacture all these new eggs so that your AMH is going to go from 0.3 to 6. That's not going to happen, But your AMH might change slightly, might improve with good nutrition and diminished ovarian reserve supplements and acupuncture. We may see a little bit of a change, but typically what we see is more antral follicles accumulating. In the ovary, in the surface of the ovaries. In other words, your ovaries are sort of getting a little more active. They're bringing eggs up that weren't there or weren't being able to be seen in the first place. So it looks like your ovaries, your AMH is getting higher, but your ovaries really just are getting a little more efficient and bringing eggs up so that we can recruit those eggs.
And those look kind of more plump as far as the ovaries on the ultrasound, or they
Ultrasound.
Yes, live expire. Okay. So the ultrasound, FSH, and all those stuff, like the full workup. So, you know, we can't just go on the AMH alone is what that's the point, right?
Yeah, I would definitely do more than just an AMH alone, because, you know, a lot of times people, you know, the labs are not as accurate as you think.
Yeah.
And people are getting misled all the time. And, you know, again, in younger women, it can be a misleading value. So you have to look at the whole picture. It's not just one little piece. That's a piece of the puzzle, but, you know, that's not necessarily the whole piece.
And you guys do free consults, I know. Like, I mean, as far as second opinions.
Second opinions, yeah. If you have records, you send us your records ahead of time, and we'll review them. Or, you know, when you come in, we'll give you a second opinion. Absolutely.
Yeah. So those of you who are on YouTube and they're watching, or our Instagram, it's IVFMD.com is where you go to request that. Because we've had certain patients that have gone to other clinics that were like, oh my God, look, everything's crazy. And then they go see you guys and they're like getting that AMH done again. And it's like, oh, it's not that bad, you know? So it depends on where you are, for sure.
Yeah. I mean, you know, it's always good to get a second opinion, you know. You have to stay with us, but you know, we'll give you an honest assessment of that, of your situation and what you should do. And, you know, obviously, you know, a lot of it is also personality. You know, you may like our doctors, you may not like our, you know, I mean, hopefully that's the case. You stay with us. But we're happy to see any one of you out there.
I hope that that you also don't give up. If you get that number, that AMH, don't give up and go, oh my God, like I'll never get pregnant. Like that's not the right approach, because we've seen people get depressed, like clinically depressed from that one number for months, and then they get it rechecked and it's normal. And it's like, what, you know, like.
Yes, that's what I'm saying. It can be misleading sometimes.
I really don't like that number, but I guess let's go on to things.
Yeah.
We are getting one more question in because we're about to actually end our Q&A session tonight. So I just wanted to ask one more question here. 40-year-old with PCOS, AMH 31.8. How much time should I give to improving egg quality? I have not done IUI or IVF, only 3 rounds of letrozole.
Wow.
31 is really high, huh? Yeah, wow.
40-year-old with an AMH of what?
31.8.
31 AMH, wow. Oh, well, you're going to be fertile till you're 80 or 90.
She has PCOS, obviously, but yes.
Yeah. Well, you're 40, so egg quality, even though you have PCOS and a ton of eggs, you know, you still have to worry your egg quality, you know, about 70%, I think, at 40 is not considered genetically normal. So about 30%, maybe 25 at that age, you know, percent of your eggs would be considered genetically normal. In other words, they wouldn't, you know, fertilize and hopefully produce Down, and God forbid, produce Down syndrome. You know, so you would probably want to be a little more aggressive now at 40. And certainly at 40, there's nothing wrong with thinking about doing IVF right away.
Letrozole 3 rounds. If that hasn't worked, then it's probably
it's time to push it up at 40 for sure. Mm-hmm. So I would consider going IVF, and you know, you may end up with frozen embryos. You know, with that reserve, you know, you're going to probably stimulate a lot of eggs to grow. So you got to be careful with hyperstimulation of the ovaries.
Yeah.
When you go through IVF. So whoever does your stimulation there has got to be very aware of that. Because your AMH is so high.
We're about to end on our Instagram feed. So thank you guys for joining us tonight. I hope we got to everybody's question.
Thank you.
This has been so much fun. This is our YouTube. So if you guys want to go to the YouTube link, it would be great to, you know, we're going to do this again. So let us know if you didn't get to your question. You could message us on Instagram. You can message me and I'll pass the message along to Dr. Gelman as well. And I'm at floridacompletewellness.com, Dr. Duro, and Dr. Gelman's at IVFMD. He's also on Instagram at Broward Fertility Expert, right? That's your Instagram? Yes.
Yep.
So thank you guys so much. Have a great night. And this was fun. We'll do this again very soon. Thank you.
Thank you.
And on YouTube, thank you guys for showing up for our first YouTube. Yay.
Yeah, it was great.
So I will definitely, we're going to do this again soon. And we'll let you guys know whenever we get Oh, there is a question. Oh, I think someone's trying to get in questions, but I'm trying to see if, since we're still on YouTube, that maybe we can answer it now.
Yeah.
Let me just make sure. Sorry, I'm doing to that question right now though, because I'm not. Let me just finish doing this here, and if you could tell everyone how to connect with you as well, just in case I didn't get to that. While I put.
If anybody wants to email me, a question, it's dr.gelman, Gelman at IVFMD.com. That's my email. So I'll be happy to respond.
To actually have this,
I think we're doing this again on July 9th.
yes, we are going to go again in July. So, but you don't have to wait that long. If you guys do have questions, please send them before that. That's going to be in a couple of weeks.
Yeah.
And then I'm going to actually post this on Instagram as well. If you guys want to go there, it's FL Complete Wellness is our Instagram, and also Dr. Gelman is at Broward Fertility Expert. So I'm going to go ahead and post this there. Thank you guys so much. I think I'm trying to get to this question before we go, just in case. Okay, we'll answer this last question, final question. Okay, in what circumstances would you transfer 2 embryos instead of 1?
Good question. We get to ask that question every day. I think if you're certainly over 40 and you've not had PGS, for example, or PGT on your embryos, and maybe you've had a couple of embryo transfers or failed already, I would transfer 2. So with circumstances, particularly in an older woman, that would be an appropriate situation to think about transferring 2. But in younger women, 35 or younger for certain, where they've had PGT testing, I would only transfer 1. And I think most places would only do 1. So rare now do we do a double embryo transfer, but on occasion it's still done in certain circumstances.
Okay, awesome. Well, thank you guys so much. Have a great night, everybody. Thank you, Dr. Gelman, for doing the time out.
This is great.
All right. Take care, everybody.